Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see, are based in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present in this channel. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of these series of talks, which span over 6 videos, is the echocardiographic analysis of left ventricular diastolic function and dysfunction as seen in the real world. It is a fast, synthetic, basic approach to this topic, which is quite large, and I will provide further on more detailed, a large video with a more in-depth approach. Now, these talks assume that you have a basic understanding on how to perform pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use tissue Doppler, myocardial tissue Doppler. And it is also assumed that you know how to perform basic echocardiographic measurements. However, you will find in the website echobyweb.com, I've just mentioned it, a large quantity of material, educational materials to address these topics. This is an outline of the 6 talks on the analysis, the echocardiographic analysis of left ventricular diastolic function and dysfunction. So the first talk we will look at definitions of diastolic function, diastology, and its clinical utility, the utility of the echocardiographic analysis. And then there will be a basic presentation of the physiopathology of left ventricular diastolic function. In the second video, we will look at how to estimate left ventricular filling pressures with echocardiography, and we will look at the current recommendations, the 2016 and 2025 latest recommendations on the analysis, the echocardiographic analysis of LV diastolic function. The third video, we will see a complementary analysis which is based on the assessment with echocardiography of pulmonary diastolic pressure, and then we will see how to estimate LV relaxation and compliance with echocardiography. The fourth video will all be about how to grade with echocardiography diastolic dysfunctions. The fifth video will be on how to report with echocardiography diastolic function and dysfunction, and we will see a series of clinical cases. In the sixth video, we will address the problem of sinus tachycardia and how to solve it, so to perform the analysis also with a fast heart rate. Then we will look on how and why to perform the Valsalva Maneuver. We will look at specific patient populations and see the conclusions. This is video number 5 from the echocardiographic reporting of diastolic dysfunction to clinical cases. So once we finish measuring and classifying diastolic dysfunction, we need to write a report of our findings, a report which must be complete and comprehensible. This is an example of a patient with ischemic dilated cardiomyopathy and grade 3 diastolic dysfunction. The report is in Italian. I will translate it to you, the essential points. I'm showing here the 2 sections of the reports with the measurements up here, and down here the comments and the conclusions that it should be. So I am omitting all the demographic parameters. In the report, there are all the measurements and calculations which are necessary to support our diagnosis. So we have, for example, I've circled in red the ones that are useful for the diastolic dysfunction evaluation. So here we have the left atrial volume, the index here, 76 millimeters per square meter. And then we have here the mitral valve flow parameter, the peaky wave velocity, the deceleration time, the D on A ratio, and then we have the annulus E prime velocity and E on E prime here. Then we have tricuspid regurgitation with the velocity here and gradient, the estimated right atrial pressure, which is obtained by the inspiratory collapsibility of the inferior vena cava. And then we have here the pulmonary diastolic pressure, the end diastolic gradient estimated from pulmonary diastolic pressure, which is 23. In the comments we write, the exam suggests increased filling pressures, reduced compliance, and markedly prolonged relaxation of the left ventricle chamber. And then between brackets, we add the grade 3 diastolic dysfunction with restrictive physiology. That's what's written here. So a complete analysis warrants that you specify always the filling pressures, which is the most important parameter for the attending physician because it determines the medical therapy that will be used. Then the grade of diastolic dysfunction to categorize the status of the patient and its prognosis. And 3, the cause of diastolic dysfunction. So the determinants, we have to describe relaxation, the compliance of the ventricle, both of them. And also it would be nice, it would be advisable to measure the extent, for example, to separate patients with mild increase in prolonged relaxation or severe prolongation of relaxation. And now let's see some clinical cases from our routine daily practice. Here is a patient with a phenotype of severe dilated cardiomyopathy, diffuse hypokinesis, severe reduction in left ventricular systolic function, mitral systolic tincting, as you see here, a marked increase on the M mode of distance between the E point of the mitral and the septum. Distance, we have left atrial dilatation, we have a left ventricular increased mass index, as you can estimate qualitatively on this parasternal long axis view. So how do we proceed to the evaluation of diastolic function? Well, our quest for diastolic dysfunction follows our routine examination. So we begin here in the parasternal long axis view, where we immediately assess, even qualitatively, that we have an increase in left ventricular mass, we have dilatation. So this is probably, if we measure it, eccentric left ventricular hypertrophy. And this tells us immediately from the first minute that we expect at least a decrease in relaxation velocity and an increase in a marked prolonged increase in relaxation. Now, the classic L-mode examination still has a complementary role, especially in the qualitative evaluation, initial evaluation in our daily practice. For example, in this patient here at the mitral valve, at the analysis, M-mode analysis of the mitral valve, we have a pattern which is called B-bump. There is a deflection here, which is called the B-bump between the contraction of the A wave and the C wave, and the C point here, the closure of the mitral valve. This is quite specific for an increase in left ventricular and diastolic pressure. In the recommendation, this B-bump here is considered as a complementary parameter. So at this point, at the very beginning of our exam, we have a working hypothesis of a grade 3 diastolic dysfunction because we have prolonged relaxation, as we see from the 2D exam, and a suspect of increased filling pressures. And this increase in left ventricular and diastolic pressure also implies that we have reduced left ventricular compliance. So our task at this point, at the beginning of the exam, is to confirm or confute this working hypothesis with the rest of the examination. We then switch to the parasternal long axis right ventricular inflow view, which is not shown here on the slide. And in this view, we perform the first continuous wave Doppler sampling of tricuspid regurgitation, which will, and the other samplings will be in the 4-chamber view of the right ventricle and also in the subcostal view if necessary. So in this short axis parasternal view, we perform the continuous wave sampling or pulmonary regurgitation here, and the end diastolic gradient here is more than 11 millimeters of mercury, which confirm that even if right atrial pressure through the inspiratory collapsibility of the inferior cava is normal, which is 6, it would give us 17 millimeters of mercury of estimated pulmonary diastolic pressure, which, as we have said before, corresponds to wedge pressure. So here the hypothesis is that we have increased filling pressures independently from the rest of the examination. This is true if pulmonary vascular resistances are estimated to be normal. Now, we won't go through with this video on the estimation of the vascular resistances of pulmonary circulation. That's the topic of another video on the right heart. But if we do a quick sampling of the RVOT, so the outflow of the right ventricle here, before the pulmonary valve, we see that the time from the beginning to the peak flow is 137 milliseconds during this acceleration. The cutoff is 100, meaning then when the time is more than 100 milliseconds, we probably have normal vascular resistances of the pulmonary circulation, whereas if the time is less than 100 milliseconds, we probably have an increase in vascular resistances. So we probably not have an increase in vascular resistances, so the measurement of the pulmonary diastolic regurgitation probably really reflects filling pressures, so the wedge pressure. According to the algorithm based on this diastolic and diastolic gradient of pulmonary regurgitation, at this point we know that filling pressures are increased, but we do need to estimate the causes, so relaxation and compliance with the rest of the examination. In this same view, in short axis, we perform another sampling of tricuspid regurgitation. We then move to the apical views, 4, 2, and 3 chambers. And here we can sample with pulse Doppler, transmitral flow, pulmonary venous flow, and with pulse tissue Doppler, the septal and lateral sides of the mitral annulus. And we can see here from transmitral and pulmonary venous flow profiles that we have, just qualitatively looking at them, it really looks like a grade 3 restrictive type of filling with a high peaking E wave, decreased deceleration, small A wave, high EA ratio more than 2, high peaking diastolic dominant pulmonary venous flow. So this supports a reduced compliance and the high filling pressures. And then we have in the background prolonged relaxation, because we have on the septal side an E prime of 3, on the lateral side 7. So the average gives us a prolonged relaxation. And then we have an E on E prime based on the average value, not this one, which is based on the lateral, of 17, which is consistent with the increased filling pressures that we have already diagnosed with pulmonary regurgitation. Then the very small pulmonary venous systolic wave tells us that a left atrial compliance is quite low, consistent with the left atrial high pressures that we have just seen by estimating increased wedge pressure. And finally, we have the parameter of the difference between the retrograde A wave of the pulmonary venous flow, which is 155 milliseconds, and the antegrade mitral A wave, which is 144. The difference is less than 30, so we don't diagnose here, as would have been expected, an increased left ventricular and diastolic pressure. So you see that in the real world here we have often contrasting parameters. In this case, this difference here doesn't confirm the high left ventricular and diastolic pressure, which was suggested with the B bump, which was known to be quite specific. Then again, in a 4-chamber view, we measure for the third time tricuspid regurgitation peak velocity, not shown here, which was in fact increased, and we measure biplane left atrial volume, which is increased from the 4 and the 2-chamber view. We index it, and in the 3-chamber view, we measure also LV outflow with pulse Doppler to calculate stroke volume, which in this patient is preserved. And in the subcostal view, not shown here, we assess, as we said before, as we anticipated, the inspiratory collapsibility of the inferior vena cava, which gives us right atrial pressure, so that we can measure accurately the filling pressures, the wedge pressure of the left ventricle. With this, we have finished our evaluation, but we have not only performed a complete analysis of diastolic function, we have also done a complete non-invasive hemodynamic evaluation of the left ventricle and left atrium. Here we have 3 examples of left ventricular diastolic function analysis in 3 different patients. In A patient with primary dilated cardiomyopathy. In B, we have a patient with restrictive cardiomyopathy. And here in C, we have an elderly patient with arterial hypertension. In A, the patient with dilated cardiomyopathy has severe reduction of left ventricular systolic function. You can see ejection fraction is 35% with dilated left ventricle. New York Heart Association class is 3. We have increased filling pressures, and pulmonary systolic pressure is mildly increased at 39. What else do we notice? If you look at the apical 4-chamber view here, as I said, I didn't say again, but we have dilated left atrium. But the left atrium is not only dilated. If you look at it closely, the left atrium has minimal differences in volume between diastole and systole. During ventricular systole, the left atrium should increase by 60% its volume during the reservoir phase because of blood flowing from the pulmonary veins. And you can see here that between diastole and systole, volume doesn't change much. So we have a severe reduction of left atrial filling during the reservoir phase, or a severe reduction in left atrial reservoir function or diastolic function. This is a qualitative assessment of what we usually do today with the new technologies and quantitate with left atrial reservoir strain. Let's look at the patient with restrictive cardiomyopathy, which has normal left ventricular volumes and systolic function here. We have increased filling pressures, severe B atrial dilatation, which is characteristic of this phenotype. Then we have moderate pulmonary hypertension, 51 millimeters of mercury. And we have, by definition, also a normal left ventricular volume, although the patient has dyspnea. And you can see here, as we have shown in the patient with dilated cardiomyopathy, also here there is a minimal difference in volume between diastole and systole. So there is also a severe left atrial diastolic dysfunction. In C, the elderly patient, 84-year-old with arterial hypertension, comes to the emergency department with dyspnea and suspected heart failure. You can see normal left ventricular volume and ejection fraction and hyperkinesis of the left ventricle. There is a reduced left ventricular preload being left ventricular and diastolic volume. Filling pressures are just to be normal, and also pulmonary systolic pressure. So is this also a heart failure with preserved ejection fraction or not? So in this next slide, it's always the same three patients. In A here, we have transmatter flow, pulmonary vein systolic flow, tissue Doppler of metal annulus, and pulmonary valve regurgitation analysis. In A of the patient with dilated cardiomyopathy, in B of the patient with restricted cardiomyopathy, and C the elderly patient with arterial hypertension. So in the patient with our dilated cardiomyopathy and severe reduced reduction of ejection fraction, so heart failure with reduced ejection fraction, the transmitral flow pattern is not typically restrictive. You see that the EA ratio is just above 1. The E wave is not high, it's about 60 centimeters per second, but the acceleration time is indeed shortened, 145 milliseconds. The cutoff is 160. But again, the A wave is not decreased as we would expect in the presence of left atrial afterload mismatch. What is left atrial afterload mismatch? It means that the afterload of left atrium, which is left ventricular and diastolic pressure, is increased, and this reduces left atrial systolic function. So when we have an increase in filling pressures of left ventricular and diastolic pressure, the A wave is reduced because systolic function is reduced because of the increased afterload. But this doesn't seem to happen here. Also, if we look at pulmonary venous flow, the diastolic wave is not increased as we would expect along with the E wave, which in fact is not increased. And the systolic wave is not decreased as we would expect in a restrictive phenotype because of reduced reservoir atrial function. The tissue Doppler profile shows is consistent with a moderate to severe reduction in relaxation because E prime is 5 centimeters per second. And it follows that the E on E prime in this case is 13, so perfectly in the grade zone. So given the clinical picture, the diastolic function here is not very clear. And if we go to our Excel spreadsheet, I told you about this spreadsheet at the beginning of our videos, which you can find this spreadsheet. You can use it on the website echobyweb.com. So this is what it looks like. In the yellow boxes are the parameters that we measure, and in the gray ones are the calculations. So we have to, and this, the purpose of this spreadsheet is to give you the recommendations, the 2016 European American recommendations. So if you insert in the required variables, you have as an output the class, the diastolic function class, and the filling pressures. So we input the ejection fraction with severely reduced, it was 35. We have an abnormal to the exam, so 2. 1 would be normal. We have the E wave is of the mitral valve is 60 centimeters per second. The A wave is 55, so the EA ratio is 1.1. E septal, E prime septal is 4, E prime lateral is 5, so the average is 4.5, and the E on E prime is 13 in the grade zone. The peak velocity of the tricuspid regurgitation is 2.7, and left atrial volume index is 40, might be increased. This gives us, from the flow chart of the 2016 recommendations, we have normal filling pressures and an impaired relaxation diastolic dysfunction class 1, which is not very consistent with the clinical picture. But if we go back here and measure pulmonary diastolic pressure through the end diastolic gradient using continuous wave Doppler of the pulmonary regurgitation profile, we have an end diastolic gradient of 14, which means that even with a normal right atrial pressure, you would have an estimated wedge pressure of 20. That means increased. So in this specific patient here, the guidelines are misleading, and I would rely more on what pulmonary regurgitation tells us. So I would give here increased filling pressures. What about the diastolic dysfunction class? I would go for pseudo-normal class 2 because the deceleration here and somewhat equivalent E on A, even though the numbers are not clear. Now let's look at the second patient with restrictive cardiomyopathy. Transmitral flow profile here, well, qualitatively it looks like a restrictive pattern, and quantitatively it is. So we have a high peaking E wave, which is almost 100 centimeters per second, and we do have a reduction of the deceleration time with 40 milliseconds. And indeed, the A wave, as expected because of the afterload mismatch, is low, below 40 centimeters per second, and the E on A is very high, about 2.6. The pulmonary venous flow is consistent with this, with a low systolic wave and a high peaking diastolic wave. So this looks like a restrictive pattern. But in contrast to this, if we look at the tissue Doppler, the E prime here is normal, quite high, it's 10. And the average was also normal. So the E on E prime is only 9, normal. Now, if we go to our Excel spreadsheet and the calculator, and we input the parameters that we have, so ejection fraction is 65, the 2D exam is abnormal, so we put 2, 1 would be normal. The E wave is 98, the A wave is 38, so the EA ratio is 2.6. Tissue Doppler E septal is 10, lateral is 9, so it's an average of 9.5, and an E on E prime is only 10. Regurgitation, peak velocity of tricuspid regurgitation is 3.4, so it's increased, and we have almost severe left atrial dilatation of 65 milliliters per square meter. At this point, our calculator gives us increased filling pressures, and we have the class of diastolic dysfunction is 3. So this is consistent with our restrictive filling pattern. But why is E prime increased? This doesn't make sense. Oh, and the pulmonary diastolic, the pulmonary regurgitation gives us increased filling pressures too, because we have an end-diastolic gradient of 9 plus the right atrial pressure, so it does predict increased filling pressure. So it's consistent with the guidelines, except the E prime, which is too high. So why this is prime high? One hypothesis, I think, would be that we have a restrictive cardiomyopathy with a reduced compliance of the left ventricle, but with relaxation, which is still normal. That's why we have a normal E prime. And this difference between a reduced compliance and a still normal relaxation can happen in a restrictive phenotype. Or alternatively, we have normal left ventricular chamber physiology, so normal compliance and normal relaxation of the left ventricle, but we have a severe left atrial diastolic and systolic dysfunction. So the normal left ventricle and severe dysfunction of the left atrium. In this case, the increased E wave, mitral E wave, is secondary to increased left atrial pressure, and the reduced A wave is secondary to left atrial systolic dysfunction, which could be post-arrhythmic, for example, immediately after cardioversion or atrial fibrillation. So there are two ways you could explain this. Always check the history of the patient. And now let's look at the elderly patient with dyspnea which arrives at the emergency department. What should we note immediately? The first thing we should note on a transmitral flow pattern, which is usually the first that we see, is a significant reduction in filling time. The duration of transmitral flow looks really short. You see here we have a very narrow E wave, and the A wave looks normal, but the total filling time is reduced. And most of filling occurs during atrial contraction. There is a very small filling, small quantity of filling during the first third of the diastole. Everything occurs during atrial contraction, which is the opposite that occurs in a normal ventricle. Which also means that atrial contraction supports most of LV filling. So that, for example, in this patient, a supraventricular arrhythmia like atrial fibrillation would cause a sudden decrease in stroke volume. So in this patient, atrial contraction does not adequately compensate for the reduction in early filling, and thus the cardiac output is reduced because we have a small left ventricular and diastolic volume. The small left ventricular and diastolic volume, even with a normal function, means that stroke volume is reduced and even at rest, and that explains the dyspnea on minimal exertion, which was referred by the patient at admission. Pulmonary venous flow is predominantly in systole, which points at a normal left atrial diastolic function. We already seen the systolic function with the A wave is normal, or also increased. And then we have tissue Doppler, which shows a very small E prime, so very prolonged relaxation, because not because of the age in this case, but because of the long-standing hypertension and mild hypertrophy of the ventricle. And finally, pulmonary regurgitation shows that pulmonary diastolic pressure and thus wedge pressure is normal, because we have in end diastole a gradient of 2.5 millimeters of mercury. If we add 6 millimeters of mercury as estimated right atrial pressure as it was, we have less than 10 millimeters of mercury of wedge pressure, so totally normal. If we go to the Excel spreadsheet and we insert the parameters, we have 75% ejection fraction, E wave is 40, A wave is 95 centimeters per second, the EA rate is very low, 0.4, prolonged relaxation with 4 centimeters per second of the E prime, and E on E prime of 10, which is still normal, normal tricuspid regurgitation, and normal left atrial volume. Well, the algorithm, the 2016 guidelines recommendations doesn't give an output. Doesn't give an output because we have put a normal exam. In fact, the exam should not be considered normal because we have a mild left ventricular hypertrophy and reduced end diastolic volume. So if we put 2 here, then it comes out to be a diastolic function class 1. And the dyspnea of this patient is iatrogenic, caused by his physician, because the patient had been given vasodilators and diuretics for hypertension, and this caused an excessive reduction of left ventricular and diastolic volume, and so a reduction in stroke volume. And also a slight tachycardia because of the vasodilator. So the vasodilator and the diuretics were taken away. The patient was given verapamil and a couple of weeks after was seen again. Diastolic filling time was prolonged and systolic stroke volume increased. It was still impaired relaxation, still normal filling pressures, but the dyspnea was not there anymore. This is the end of video number 5. Please proceed to video number 6 from the analysis of tachycardia to the conclusions.